So for long-headed biceps tendon, to assess for long-headed biceps, we palpate, find our bicipital groove, and then put our probe straight on. So palpate, probe sits straight on. So we'll have a look in short axis first. So we find our long-headed biceps, we follow it down into the bicipital groove. We're going to follow it down, chase the biceps the whole way down towards its musculotendinous junction. We can see our pec major insertion in through here, and then it starts to form its muscle underneath. So we see our biceps long head form its muscle under the pec major insertion. We're going to follow our long-headed biceps up into the rotator interval. And you notice that the hand position is in a nice, neutral, relaxed position. It's a nice way to assess biceps. So palm up, hand in lap, palpate the groove, probe on, follow down towards the musculotendinous junction, under pec major into the muscle belly, and then back up. And as we follow up over humerus, we need to fix for our anisontrophy. Remembering that the humerus is a ball-shaped structure, and the long-headed biceps comes up and rolls over the top. So we're going to, as we bring our probe up, we roll our probe up to fix our anisontrophy. So our probe transitions and rolls up to stay perpendicular to the collagen fibers of the long-headed biceps. Now we're up in our rotator interval. And we can see our coracohumeral ligament sitting on top. We can see our superior glenohumeral ligament sitting below. And we can notice that the medial aspect of our superior glenohumeral ligament chocks the long-headed biceps up medially, so it holds it up medially. We can see the blending of fibers from the top of subscapularis going into that rotator interval. And we follow our biceps up as high as we can get, sometimes taking the arm into a bit of extension, into a bit of a modified Kras position. We'll put it on a bit of tone. Sometimes it'll help you, sometimes it won't. So try around in a few different positions. So we follow up, and here we can see a really nice image of the rotator interval with our coracohumeral ligament sitting on top, our superior glenohumeral ligament sitting underneath. We can see our coracohumeral ligament bridging down, going underneath our supraspinatus, merging into the rotator cable, going on top, those fibers extending on top of our supraspinatus. Then we can see the top of our coracohumeral ligament running on top of subscapularis as well. So it envelops those tendons, holds them in. So nice assessment of our long-headed biceps and our rotator interval. We have a look here, just from that neutral, just relax that arm, neutral hand in lap position. We can appreciate the top fibers of our subscapularis. We can follow our subscapularis down towards its muscular insertion and up to the top to its true tendinous insertion up the top. As we get up the top here, we start to get into those top fibers of the superior glenohumeral ligament. This is where we want to look for the irregularity, the enthesopathy of the lesser tuberosity. Up in through here, this is where you're going to have your pathology. So we have a look at the enthesis of subscapularis. We have a look at it in a neutral position, and also in a little bit of external rotation. Have a look at the enthesis, and have a look at a lot more external rotation. So assess it in various degrees of tone. External rotation followed down, have a look at that enthesis footplate, and it's the top fibers where you want to pay most of your attention. Subscapularis in through there, relax it down. For your injection therapy, injecting your long-headed biceps up at the rotator interval. This is the nice way to do it, standing behind your patient. Grab your long-headed biceps around the level of the rotator interval or at the level of the bicipital groove, and bring your needle in from a posterior approach, coming on down, dropping on down at about a 30-degree angle, and you can nicely inject in through here, injecting around your long-headed biceps, and remembering that this is not only a tendon sheath injection, but it's also an injection into the glenohumeral joint. So it's a joint injection as well as a tendinous injection. That's for biceps, subscapularis, rotator interval, and biceps injection.